So I'm now going to introduce our contributors. First of all, we'll be hearing from Dr. Robin Dowling, who will summarise the findings in the Culture and Referral Research Digest that we're discussing this morning. Then we will go to our panellists for their responses to the findings. Our panellists are Professor Helen Chatterjee, Professor of Biology at University College London, Emily Bradfield, who is Director of Arts and Minds, Christiana Mellam, Chief Executive of the National Association of Link Workers, and Gavin Clayton, Chief Executive of Hoot Creative Arts. So I'm going to hand over to Robin now.
Thanks so much. I'm just going to share my screen. Okay, so I'm going to give a quick overview of our rapid review, which has been published as a research digest on arts and cultural referral programmes. And while I won't be able to cover everything in detail, I'm going to just give an overview of the key findings. But if you want to read it in full, you can find it on the resources pages of our website. So why did we decide to focus one of our reviews on this area? Well, in recent years, there's been more popularity from both the cultural and health sectors as a way of addressing health and wellbeing needs. And here are a few of the reports which include either evidence syntheses relating to social prescribing through the arts or provide recommendations advocating for this approach. So while there have been reviews which focus more broadly on social prescribing, we wanted to examine peer-reviewed articles which specifically focused on referrals to cultural experiences. Because our reviews are rapid in nature, we limited our searches to peer-reviewed literature published since 2010, where the cultural referral programme was delivered by a cultural organisation, cultural practitioner or community group, and had a focus on health or wellbeing outcomes or the process of taking part. We didn't include studies which included creative arts therapies, and while we recognise the vital work of creative arts therapists, our focus was on the impacts and outcomes of work produced and supported by the arts, cultural, heritage and screen sectors. We also excluded programmes that would fall under the umbrella of culture, health and wellbeing, but did not have a referral element to them. So we asked the following questions to guide our synthesis and appraisal of the literature. So what evidence is there to support or challenge the impacts and outcomes of cultural and referral programmes on physical, mental health and wellbeing? How are these impacts and outcomes researched and evaluated? And what are the perceived strengths and limitations of the research at this moment in time? And where are there gaps in our understanding, and what does this mean for future research? So the following slides will give an overview of the types of studies we identified, and this will be followed by an overview of our synthesis, which includes what we know for certain, where there's emerging evidence, and where further research is needed. So we identified 13 studies which specifically reported findings in the context of cultural and referral programmes. 11 of these focused on programmes in England, 1 in Denmark and 1 in Australia. And at this point, I'll note that all of the studies had a focus on mental health and wellbeing, and there were no studies that directly examined physical health related outcomes. So of these studies, the most commonly reported focus was on a mixture of cultural experiences, either visual, creative or cultural. The most commonly reported programme length was 10 weeks, with it being most reported having a 2-hour session per week, and the longest was across 6 months. Many participants across these studies shared similar demographic characteristics when these were reported, with most being referred due to mild to moderate stress, depression or anxiety. A large proportion of participants also self-identified as female, white, and were aged 50+. 2 of the studies focused more specifically on the referral of older adults to arts and cultural experiences, whereas the remaining studies had a more general focus. There was a pretty even split across studies when it came to the use of qualitative, quantitative, and mixed method studies, Qualitative studies tended to use interviews or focus groups. The quantitative studies largely use standardised measures of wellbeing, such as the Warwick Edinburgh Mental Wellbeing Scale, or WEBWEMS, and the Museum Wellbeing Measure for Older Adults. And the mixed methods studies used a combination of these approaches. Also noting that there was one study that had a more longitudinal approach, but rather than following participants over time after the study, it was more a longitudinal evaluation of the programme itself over different cohorts. So what do we know for certain? Across the 13 studies, all showed positive outcomes relating to participant wellbeing. In studies that use standardised measures of wellbeing, and this was typically the WEMWEBs, all but one showed significant and meaningful changes across the duration of the programme. And the one that didn't showed positive changes still, but it wasn't indicative of meaningful change stated by the authors of the WEMWEB scale. In terms of qualitative studies, participants reported that they felt more confident and had better self-esteem. They felt calmer, more relaxed and less anxious, as well as reporting feeling less lonely and isolated. Participants also reported that they had made friends and that they appreciated being part of a group who had a similar lived experience when it came to mental health challenges, stressing the importance of peer support and the opportunity to develop new friendships within the context of programmes. Though we can say with some certainty that cultural and referral programmes had a positive impact on wellbeing, it must be noted that very few studies described or appraised the cultural experiences themselves in any great detail. This means we really don't know a lot about what happens in sessions and how this may lead to changes in wellbeing that we observe. While we're not trying to instrumentalise the value of arts and culture within this context, more needs to be done to showcase the specific value of the cultural experience itself for those who take part. And this is particularly important given the social prescribing context in which these programmes fall within. So we need to be able to say with confidence that it is the art and culture that's making the difference above and beyond what could be achieved by just sitting people in a room together without the art and culture there. So where is there emerging evidence? So across a few studies, there were observations relating to the ways in which cultural or referral programmes were stepping stones to other activities or ripple effects. So for example, some participants enrolled in arts courses at colleges, some established their own arts groups, and some engaged more with creativity in the context of their own homes. Given one of the core aims of social prescribing is to create greater links between people and communities to enable longer-term health and wellbeing aims, this is an area that should be considered going forward so that we can gain greater understanding of the more long-term impacts outside of the context of a 10-week programme. Finally, where is further research needed? And all of these points are prefaced by the fact that we know that there are many cultural organisations and practitioners who are seeing the difference that arts and cultural experiences make as part of social prescriptions. But our core aim with these reviews is to understand the strength of the evidence base and what approaches might be necessary to strengthen it. So as I said previously, it's difficult to disentangle the value of arts and cultural experiences from the group-based context in which they happen. And this is largely because there's a real lack of detail when it comes to describing and appraising the cultural programmes themselves. We don't know what happens in the moment when people are actually in the process of engaging. And this is because it's just not described. So in some instances, we had so little detail as just mixed visual arts with no other detail attached. Secondly, there's a lack of longitudinal evidence, and so we can't speak at the moment with confidence to whether cultural and referral programmes make a difference in the longer term. We know that cultural organisations are embedded strongly within their communities, and we think further research is needed to understand whether these programmes can indeed enable people to feel more connected to their communities, which may in turn lead to more sustained improvements in wellbeing at both a personal and community level. Thirdly, there's a lack of detail when it comes to reporting the context in which these programmes take place. We know that social prescribing operates in different ways across the country, and none of the studies went into any great detail about how people were referred, why a cultural programme was most suitable for their health and wellbeing needs, who they were referred by, the healthcare context from which the referral came, and whether outcomes were reviewed again by link workers and GPs, or whether it was just purely for research purposes. So we need to know a little bit more about the complex settings in which these programs are part of to be able to develop more sustained programs that can stand the test of time. So finally, a large majority of participants shared similar demographic characteristics, self-reporting that they were female, white, and aged 50 plus a lot of the time. So although we can't determine whether this is the cultural and referral programs themselves or taking part in research that's causing this lack of diversity, this warrants attention going forwards. We need to ensure that both programs and research are accessible to a wider range of people to ensure they're not contributing to wider inequalities that may be experienced by different communities. So in conclusion, while all of the studies showed positive outcomes to relating to wellbeing, we have to be a little bit careful when interpreting this evidence. While we have come some way in the past 10 years to showcasing the value of cultural experiences within this context, we still need to know a bit more about the arts and cultural programs themselves, the wider context they're a part of, whether there are any lasting benefits after the program. And we really need to question how diverse and inclusive programs are. So now to let you know our next steps with this review. We're wanting to get your feedback on this digest, both as part of this event and going forwards. And I look forward to the panelists' responses as well. So we'll be updating the review next year. And we really encourage you to send us any new publications or anything you think we may have missed. So please get in touch. We want to hear from you and looking forward to the discussion. Thank you so much.
Thank you, Robin. Thank you very much. I'm going to pass straight over to Helen Chatterjee now.
Hi everyone, it's lovely to be here. Thank you for the invite, Centre for Cultural Value, and thank you and Robin for this report, for pulling together this synthesis on arts on prescription. I think it's always useful to have accessible reviews and syntheses like this on hot topics like social prescribing, and we know social prescribing is a hot topic, isn't it? A few points of what most struck me about the report. The first is the very small number of peer-reviewed papers that exist on the topic explicitly if you're looking for arts on prescription. And I think what this does is allude to some of the challenges that we know we face regarding the evidence base for social prescribing. We know, of course, that there's a lot more evidence out there if you look beyond social prescribing and arts on prescription, particularly if you explore the wider field of arts engagement and health. So, for example, the All-Party Parliamentary Group for Arts, Health and Wellbeing's Creative Health Inquiry cites over 1,000 different publications. Some of those are peer-reviewed, many of them are grey literature and other sources of information. But as our Culture on Referral report suggests, we know that we need more rigorous reviews and research in this area. We need to address some of the key issues that Robin's just highlighted. We know we have issues around sample sizes. So many of the sorts of interventions and programs that are being evaluated and researched are run with very small groups, and that's reflected in the types of studies we see. So we know we have an issue around sample size. We know we have an issue of a lack of control groups, and there's a lot of discussion about what constitutes a control group for studies like this that are complex. And also, as Robin's mentioned, we know we have an issue around a lack of longitudinal studies, and it's really important to understand what are the long-term impacts of arts and cultural engagement on health. I think the review makes a really important point about whether wellbeing outcomes are the result of the arts and cultural activity or whether it's due to social connection. And I think it's interesting to try and unpick this and ask if it's useful or even possible to separate out such social outcomes, as many complex non-clinical interactions involve lots of interlinking connections, which is why we find it so difficult to control for those sorts of interactions when we're doing research. And why I think it's important to have a more holistic, integrated or person-centered approach when we're talking about research. And I think that links to some of the areas that we're most interested in adapting research and finding new ways that we can look at a more neurobiopsychosocial model, which includes the ability to look at the whole person, the physical, the physiological, the psychological or self-report, and social, which is why I always advocate using a mixed method approach. This way, hopefully, we can begin to unpick some of those challenges that we've talked about around what might be called the active or key ingredients in programs, so that we can begin to develop programs that we know are already existing out there that deliver the maximum wellbeing outcomes to the widest range of participants. And finally, for me, what I thought was also really important was the point highlighted in the report, which alludes to the fact that it's difficult to understand the role of different arts activities in relation to health outcomes. So, for example, looking at dance versus visual arts or crafts engagement. This is important, and it's really important to understand how different types of tasks and activities and participation leads to specific health outcomes. But it's also important to be asking the right sorts of research or evaluation questions, and critically that we're using the right sorts of tools and methods to answer those questions. I think finally, it's also really important to understand all of the different elements that feed into arts on prescription and social prescribing more generally. That's from the direct point of referral and why an individual has been referred, the whole referral process or the mechanism surrounding that referral process. We've talked already about the importance of understanding the impact of the intervention, but also we need to think beyond that, how that links to the wider aspects of that individual's own health, their well-being, their behaviour and the lifestyle and the community that they live in. Social prescribing is a complex non-clinical interaction, as we've talked about. It's operating in a complex ecosystem with multiple stakeholders and multiple partners. So we need to understand the complexities of that relationship in order to make social prescribing successful for all those involved, but most importantly for those participants that we're looking to deliver health outcomes for. And I'll end there. Thanks, everyone.
Thank you very much, Helen. Okay, we're going to go to Emily now.
Thank you, and really interesting to kick off with Helen's research focus. I feel that I'm torn in two places here, from a researcher and a practice, so hopefully I'll be able to follow on from that. As speakers, panelists, we were asked to give our reflections in 4 minutes. So being the visual person that I am, I've done a visual thing which I'm going to use, but I focused on 4 key things that I really thought were interesting from the report. And the first one that struck me was language, and the fact that this digest is called Culture on Referral. I think within the field of arts and health, we have a lot of terminology, different terminology and language being used. And I think it's really important to just take a minute to think about that. Looking at the studies included in the report, we have arts on prescription, arts on referral, social prescribing, social prescription, eco-creative green programs, arts-based programs, museum-based social prescribing. So within our one field, we have a real mixture of different language, which I think can be confusing, but also it shows us the diversity of practice that actually is happening, which is exciting. And as Helen said, you know, there are, when we talk about culture or arts, that's a really wide range of activities that can be really relevant for different people. One person might enjoy a singing program that they are referred to, whilst the other person might enjoy an visually arts-based or a museum program. The other thing that I think is interesting from a practice perspective is at Arts and Minds in Cambridge, we run arts on prescription, but it's museum based, but we call it arts on prescription. So that's an interesting reflection. My second word was, well, 3 words: equality, diversity and inclusion. In terms of both the programmes, but also the paper, the digest. Who's the audience was one of my questions, more than a reflection. Who is the intended audience of this, this digest, and how accessible is that digest for the intended audience? People who know me will know that I'm very focused on creative methods, and we are talking about cultural engagement, creative engagement. So can we present these findings in a more creative way, was a question again, and a reflection, but also thinking about how can we make arts on prescription programs or culture on referral programs more accessible for the people who are benefiting from them. And that's something, again, we're doing at Arts and Minds, is really looking at an assessment of how accessible our program is and how we can make that more accessible to a wider audience, whether that's with a blended approach of doing some things online which means you can reach a wider geographical area, or whether it's about how we advertise, publicise, get referrals and so forth. Point 3, learning. What can we really learn from this report, and what can we learn from previous papers on the subject? So Helen and others published a systematic review of social prescribing in 2017. Hilary Bungay and Stephen Clift provided a reflection in 2010 on arts and prescription in the UK. This was sort of a question really as well. Has there been any sort of overlap and review of any changes that have happened in the newer publications? That would be really interesting. What can we learn as we come a decade later? And what can we learn taking forwards, both for research and for practice? I think there's some really interesting questions around the space. So again, where these activities are taking place, the environment that they're taking place in is really interesting. And then finally, practice. So what are the implications of this? Again, this is a bit more of a question. What are the implications for practice? How can research and practice work together better in terms of evaluation? For practice, what can we learn for this to improve our evaluation so we can increase the evidence base? And how can we work with research to share practice, to share learning? And that's lots of questions and reflections.
Thank you, Emily. Okay, so we're going to go to Christiana now.
Yeah, hello, hi everyone. It's great to be here today, and I'm looking forward to an engaging day and discussing with you all. So whilst looking at the digest, I had a few sort of like reflections, and overall, any evidence is quite useful, because we know social prescribing, as Helen said, is on the spotlight and there is a national policy backing. So for that, and we are quite short on the evidence base for even any of the social prescribing activities. So any evidence that is geared towards social prescribing is quite welcome, is quite useful as we continue to grow the evidence base. So culture is one of the menu that social prescribing link workers have. That's one of the options. So we call that social prescribing activities. Some people call that a prescription, some say referral, different terminology that's available to them, but it's based on what matters to the person. And we just need to also remind ourselves that the national policy drive for social prescribing in England is based on the link worker model, because interventions are not working effectively because there is no link worker to support people to access those interventions and even walk through to find out if those interventions are the right interventions and unblocking the barriers. So my background is public health and health promotion, and sometimes you just have these interventions and it's not really very effective because there's just that gap there. So the link worker is the bridge, and I wanted to see from the research, from the digest, to see what model, so where did this referral come from? Is that referral from the link worker? Because it makes a huge difference because they're there to unblock the barriers and also making sure, and they make observations from a complex and a holistic point of view. So some people get a bit confused with term prescribing. Well, we're not prescribing actually, we are co-producing solutions with the person to enable them come up with their own solutions, unblocking the barriers, and we are aware of the many of options that is available to them. We then help them to assess that and make sure it is working, unblocking the barriers across as we go on. So it'd be interesting because some people, the GP referring or anybody referring, that's active signposting, that's not social prescribing as far as National Association of Link Workers is concerned. And also the national policy for England is about that link worker model. So I wanted to kind of like see that differentiation and maybe people checking that, because there are certain interventions that if you're having a social prescribing as part of a treatment, I think that's slightly different because what we are talking about here is a social model of health where we have we are medicalizing our condition, we are medicalizing our issues, and we've got the healthcare system that is not empowered to support people to come up with their own solution, to stop medicalizing things that are actually social. So what social prescribing does is to bring together the social model of health and the medical model so that we're providing holistic well-being to people. And ultimately it's about reducing the inequalities and reversing the inverse care law. So a bit concerning in terms of, I appreciate it's a small kind of like study, but we need to make sure that, you know, we're actually reaching those that will most benefit from this, and looking at the vulnerable groups that like to see people with potential severe mental health issues, and just checking if they are also benefiting from these sort of interventions, and also the vulnerable groups and the people that benefiting from social prescribing or culture on referral as well. Another thing that I also had is we sometimes get in the terminology and around community and organizations. Well, some of the organizations and some of the culture and arts or whatever people sector that they feel will be useful for their health and well-being, it's often people coming together and filling those gaps. So there is no, they're not registered anywhere, they're not a charity, and it's person-centered. So we had just had our Link Worker Day 2020 awards, and the community group of the year winner was Program Scotland. It's a GP practice that recognized there were gaps for young people, and these young people were falling through the cracks, and they got a bit of grant funding and were able to put that together. The Link Workers put that together, and the young people actually co-produced that community group, and then they came up with some creative ideas and doing things around arts and all of that. So let's just be very careful, because social prescribing, we are made, the Link Workers, to provide tailor-made bespoke solutions to the person. So it's about what matters to the person and what they want. So for these young people, they did not actually fit into any organization, and what they wanted and what mattered to them was what mattered to them. So there was no provision out there. So I think what will be very helpful is for the language and the messaging being that we know that social connections and social identity is quite very important and has a role to play in our health and well-being. And this is feeding into the growing evidence of that. But then we make sure that there is some capacity funding to enable the social prescribing programs to be able to support people assess the social prescriptions that matters to them, as opposed to just saying it might be this culture organization, because they might need to set up their own bits, and then it's about the community. Then there's a question there in terms of sustainability, because that's the difference of the role of the Link Workers, about making sure so that the person can cope and making sure that the community is resilient to support them. And even after that program, well, it shouldn't fall over, because otherwise you're going back again. We already had previous intervention that did that and it didn't work. So it's quite useful to actually then make sure that the essence of the social prescription ultimately is to empower the person, take control of their health and well-being, and that is sustainable, which then leads to sustainable behavior change. And the last thing that I'm going to add to this is, let's not be very too ambitious, the research, because it's difficult to establish cause and effect. Because like Helen said, and Emily you said as well, the social prescribing landscape is a complex intervention. So you're not just looking at one aspect of the person's life, and it's a complex intervention that requires a complex number of stakeholders and individuals and organizations to play a role. So this is something that is unique about it. It cuts across all the sectors. So you can imagine the National Association of Link Workers, we get, I can see community transport team on there as well. We get the physical activity. All the sectors are coming down on the Link Worker, because it cuts across every aspect of person's life. But what we haven't got is a consensus in terms of having a research evidence that is consensus that says, okay, we know that some bits that are concerns around social identity and loneliness, we've got the British Red Cross on that. We've got a number of all this research from various sectors, but then coming together, and then we can say, we know that this actually works, it does this. can we then get a resource of funding across this, rather than pitching against each other or saying that is that. That's not the way link workers work, because we're meant to offer tailor-made solutions and personalized support to this person, and it might not fit what you think is what they need, and we need to be able to respond to their needs. Thank you.
Thank you, Christiana. That was so helpful. Okay, so finally, we're going to hear from Gavin.
Thanks, Alex, and thank you for inviting me along today. I'm just going to start my timer. So that I do 4 minutes. Okay, so yeah, on reflection, I'm really glad to see it. It was, you know, I've been involved in Arts on Prescription for 15, probably 15 more years, nearly 20 years. So a lot of it felt quite familiar. And I don't mean that in a disparaging way at all. It's really good to remind ourselves about the questions that we keep asking ourselves. I think there's some important questions in our sector around language, again, in the way that Emily mentioned, around participatory arts and community art, and also around cultural democracy and democratization of culture. And I think those are really interesting things to bear in mind when we're talking about this sector. And for anybody who hasn't read it, A Restless Art by Francois Matarasso is a really good read, and it's got lots of stuff on that, far more articulate than I can do, and certainly in 4 minutes. The work centres for me, and it has done for that period for my professional career, on around the facilitation of a person in achieving a self-actualization that comes through that engagement with the arts. And I think that's really important to bear in mind. And I think the arts, the way the arts does that is unique, and it is over and above belonging to a group, simply belonging to a group. It's additionality to that belonging. And I realized that this search for the examination of the complexity around that and how it works is really interesting. However, my worry is that if we spend our time looking at, you know, this particular form of art achieves this particular health outcome, while that is an important aspect, I think what we need at the moment, post-COVID particularly, or during COVID, we need a more generalized public health study predicated on the fact that it's now accepted. You know, the report says the NHS England happily states social prescribing has beneficial impacts for a wide range of people. That's great to hear. So if we've won that battle, then where do we go from there in terms of research? I was interested in the prescription length. I think it was page 13, it had a table of the lengths of prescriptions. And again, that specificity, you know, in the context seems to be the time limited nature of it, although I've been involved in setting up time limited programs myself. That seems a bit incongruous, when in reality, you know, prescription drugs, for example, you know, somebody like me who's got rheumatoid arthritis, chronic health condition, I'm going to live with it for the rest of my life. I'm on medication for the rest of my life. I've not got a 6-month dance class to help me with stretching and then that's it. You know, I will be on medication all my life. So why can't people be on an arts prescription for the rest of their life? Why does it have to be just 10 weeks? Agreed again with Emily about the language culture on referral. The other thing that surprised me was, and forgive me, Christiana, if this, but the idealized sketch of how the link worker system works that's described in this report. I would be interested to hear your reflections later in the meeting about whether the link worker system does work as smoothly as it's stated in this report, especially when there are organisations like Hoot Creative Arts who work with creative support workers to sit down and develop what we call a creative arts plan with every participant who's referred, which is basically a link worker role. It's what you're talking about, co-production. That happens outside of the link worker frame as well. And how do we bring those two things together? The reality of that happening within the voluntary sector and the establishment of this structure that you are part of. I'm really interested in how that meshes together. I've got loads more to say, but I'm aware my 4 minutes is pretty much up. I want to say one thing, which is that if we're going to look at that specificity, in the same way that Big Pharma, for example, looks at specific pharmacological interventions, we are not going to have the same money at our disposal to do that research. So I think we have to make, as a sector, it would be quite good to make a decision at some point about how we look at the problems going forward that we're facing right now, when there is a new imperative to look at work and collect and evidence the evidence around digital delivery at the moment, and also the kind of public health inequalities crisis that has been accentuated during COVID, that we really need to look at as well in terms of the mental health and impacts of COVID, and how we recover from that as communities, as individuals. And that's something in terms of where we focus next as a research community, I'd be really interested in seeing. I've got loads more, but I'm going to stop because I'm already over time. Thank you very much.
Thank you, Gavin. Thank you. And just to say to all our audience, I know you are talking to each other in the chat and asking questions, and we will have an opportunity to have questions and invite you to ask questions to the panel. But first, we're going to go straight into breakout groups, which again will give you a chance to talk to each other. There is a question for these breakout groups. They're going to last for 10 minutes. They're a chance for some quick fire networking and to get a sense of what other people are thinking and interested in. And there is a question there on your screen. Okay, it's now 11:58, so I'm just going to bring our panelists into a discussion with all of you via the chat. And as I say, I will invite some people to switch on or to switch on their microphone and ask their question themselves. You've been putting into the chat what you discussed in your breakout rooms. The question was about how do we evidence this? So some people have talked about methodologies, which I think possibly might be a good starting point. And to our panel, so there's this question of how you do you measure all the complexity, I think. Sorry, I'm just trying to find the one that made me think of that. So I don't know if you can all see these. So the art forms are all different, and some are more collaborative and some are not. And it's how do you approach, maybe have a sort of overview of methodology that could look at that. And then the other thing, so is the need for ethnographic type evidence. So how much art, how much social engagement, what is facilitating the how is one way of considering that perhaps. But I was also interested in this question, which I personally think is a reflection, which is that the creative activity can enable people to connect in a different way because they're busy doing something, as well as having to, maybe talking to each other or not. I think this one from Anne Wishart, by participating in group arts activities, people are engaging and do not have to talk about their personal experiences. Busy hands, busy doing something, learning a new skill. They may choose to talk about their personal experiences, but that isn't the focus of the gathering. So panelists, would anyone like to comment on those observations from the breakout groups around methodology? Helen, go to you first.
I can have a go. Yeah, I mean, I absolutely agree. I mean, firstly, it is complex, measuring complex interventions because of the complexity, but I don't think it's impossible. I think exactly as you've just articulated, Alex, and many people who've been delivering these sorts of programs, activities, interventions for a long time, they understand very well what those benefits are. And it's unlike many clinical interventions, what we're actually seeing is multiple outcomes and multiple benefits. And what's hard then is capturing that, which is why I was advocating approaches where you can use methods that include, for example, ethnographic as alongside the self-report psychological, maybe alongside more physiological or physical measures, because it's actually the activity themselves, which, as you've highlighted, Alex, is where we know the benefits arise, and that people, when they report the benefits, say in terms of psychological well-being improvements, in terms of having social connectivity and reducing isolation, improving self-esteem, it's because of the actual activities that they're involved in. And I would argue that those benefits are because those activities are non-clinical, and they have creativity at the heart of them. So when we're thinking about things like what are the core ingredients, active ingredients that are going to work in a program, it's about making sure that that's embedded into the program. And there's lots of other, I think, ingredients that we need to address as well, but that having that at the core of it is really, really important. Like Gavin's got a point as well.
Thank you, Helen.
Yeah.
Yes, Gavin. Yeah.
Thanks, Alex. I just wanted to pick up on that. I think also what's really important is the relationship between the organisation or the artist that's actually delivering the intervention, and often, and in the case of who we deliver within personality disorder pathways in prisons. So it's a very, very specific kind of psychosocial model that has been developed for these particular centres within the prison system, and working closely with the people who devised those systems, and so that informs the design, the co-production, the design of the model that then goes in this case, into that institution to work in very, very particular ways. And it is the fact that it's non-clinical that allows the interactions, the positive interactions between people in that particular setting. It's all about encouraging, very positive relational exchanges between people who have real problems with that. Yeah, I just wanted to add that very specific kind of, and it's the relationship between the setting, the artists, and the organisation that are kind of heading that work up.
Yeah, I just want to add in and maybe ask Christiana about this, because in a way, your point about the fact that co-production is at the heart of the solution, and we're talking about activities where people come together, rather like you were pointing out earlier, we're talking about organizations that can deliver activities. But I think you were trying to pull us back to the importance of the co-production and the person-centered element to the work that the link worker does. So how do we evidence what methodology could be meaningfully used in something that's more around community development and co-production than perhaps around an organizational approach?
Yeah, so I think, again, it depends on what matters to the person. So if it's part of a treatment or the person is going there to acquire a new skills to get work. So there are some of the people that benefit from such prescribing or the link worker support, and they enjoy painting, or they want to become a dance instructor because from there they can earn a living or they can get a job. So it depends on the person's motivation. Then maybe they're not feeling isolated or lonely. So of course, then being in a group is also another added advantage. Whereas somebody who is joining this group to actually support their social isolation, as well as reconnecting with their hobbies. Not everyone who wants to find a job. Some people are joining these groups because it's a hobby that they've been doing over the years, and now they want to reconnect with that hobby to get a bit of busy and volunteer. So again, if we adopt a personalized care approach based on what matters to the person, that is what will drive the model. And going back to how we are as human beings, we love to connect. We are social beings. So anything that we have that does not include the connectivity, well, how are you going to sustain it? It's just not possible to fund all these programs like forever. Look at what's happening with the COVID situation. The NHS couldn't cope without having the multitude of volunteers and people coming on, and we couldn't cope without having neighbors and people's goodwill. So again, building in resilience within the community and making sure that there is that connect is absolutely very important. Otherwise, we're going back to what we already know, refer this person to this, and then they go there. Because I'm just like that. I attend a Zumba class, and I just tell you what's kept me going is the group. We set up our WhatsApp group, and then, oh, you're coming today? Are you not going to come? Now we've gone digital, and they say, oh, come on, you want to come on. So is that sort of thing is what is sustaining it. So I think we really need to focus on sustainability, and it's also what matters to the person and building in that connectivity in it, that ultimately has to be the driver, because that's what has been the differentiation. If there is no sense of ownership, I'm just being referred here by my GP or by my doctor, there's no sense of ownership, or I've got other factors that are stopping me from engaging in that, then that becomes problematic.
I think, Christiana, in a way, you're offering a different research question, and there is from one of the groups, Laura Broom says, asking the right questions in research, and you're really saying what the research question has to be about that personal activation, person-centered approach, rather than possibly the notion of an intervention. I think that we're on a continuum here, and I want to go to Emily briefly, because arts on prescription, as I understand it, sort of over the years that it's been happening in Cambridgeshire, was a more specific intervention around a more specific health need. And I think this is the territory which we're trying to span it all, but it's a lot of stuff. Emily, did you want to respond to that issue of methodologies?
Yeah, and I think the point earlier, or that we've all been sort of saying, is these are complex activities with complex needs, but also with complexity in terms of people, because we have to remember that without our artists or facilitators, arts on prescription programs or culture on referral or garden therapy or whatever it is dependent very much on a facilitator. And so I think we need to, when we're thinking about methodology, is how do we bring in, as well as keeping the participant voice, which is crucial, how do we bring in the other voices that are really integral to the delivery? So for example, in an arts on prescription program at Arts and Minds, we have a professional artist and we have a counsellor. Those are two very different viewpoints coming in, which are integral to the Arts on Prescription programme, which are essential to the Arts on Prescription programme, and that needs to be incorporated. And so an ethnographic approach might be suitable, but also can we not forget that we are working with artists, so I'm going to bang on about it. Let's bring some creativity into our methods, please. It's so important. We are working and championing the benefits of creative engagement, and so let's bring some creativity into our methodologies.
And presumably co-production of research itself, which is another issue. Okay, I'm going to try and move us to some of the questions that have come in, that came in earlier, or people are asking now. So please do start putting in other questions. We're recording all of the chat, so we have it all there, but I would like to invite some people to ask their own questions. And I'm just going to trawl through and see if there is anything that we particularly want to pick up from earlier. And if you're going to put chat in now. Okay, so as you got a question in, Azita, would you like to ask your question to the panel? Can you unmute yourself?
Hello, hi, yes, sure. So yeah, I mean, as I explained, I've done a very small research on the social prescribing as a trainee in the museum sector for Paisley Museum, and it was very interesting in Scotland, in England, and in Ireland. There are a lot of programs, looks like it. But I'm just sort of wondering about Christiana's point about engagement of the community, which I can see the benefits of it for sure. But I'm just sort of wondering, there might be some individuals which don't feel comfortable with their own community for various reasons. There are different biases going on, and so it might actually put them off.
Okay, so Azita, are you referring in a sense to a diversity issue, or people who are marginalised and may not be connected into their community?
Well, both of those issues, yeah, both of them. Just not feeling very comfortable within your own community for various reasons.
Yeah, I think that's a really interesting point. And Christiana, I did want to pick up on your question around it's connected to the co-production, but also the notion of community development, which I think the creation of new groups led by individuals who decide they want to do something rather than a professional led group. What's your response to that issue of people not feeling comfortable in their communities?
So I think the link workers model is about a social model of health, which is about all the social determinants and all those health inequalities and all of that. And then they facilitate, connect, and link to the community support solutions. So that requires good old community engagement and community development. However, there are some schemes, they don't need to take that up themselves because there are already infrastructure organizations who are meant to build that from a bottom up. But they do help people to access those services and those supports. So like in this example, it's not only just about a diversity issue. I might have moved to a new area and I've got no friends. I have not integrated within that area. And then you refer me on to this cultural group. Well, where do I actually start from? So then the link worker can actually help and support them to engage and go there with them. They do that, they go there. So that's why they're very crucial in anything we do. If we lose the link worker model, well, we go back to zero, because it's about unblocking the barriers. People are capable. There is no hard to reach group. There is no, people are waiting for us to find them. We need somebody who is on the ground that can actually help to unblock the barriers. Again, if there is a gap where there is a group where they don't identify with, the link worker might have all the people that they are supporting, that they can put them together. That's the beauty. Then they form their own support bubble, they form their own community group. But absolutely, it has to be driven by what matters to the person, tailor-made to that individual, and the link worker able to identify gaps. I mean, there are some models in some areas that I like where the money follows the person. So you can't just say referral to this group. No, because some of those groups are not culturally appropriate for them, or they don't feel they want to fit in there. But then they have got the funding where they can actually join the group or attend a group where they think they feel more comfortable. So I think there's a thing there about social identity.
And also, in a way, what you're saying about the funding, it's power and control, isn't it? So part of the role of the link worker is to empower the individual to make those choices through that personalized care.
Put the power back to the person. And that's the only way we're going to achieve health reform, is empowering the individuals, empowering providers of care, empowering the link workers, empowering. Otherwise, we're going back to square one again, disempowering people or increasing inequalities, in hindsight.
Yeah, and one of the questions actually is, are there any models in social prescribing where funding follows the referral? I think what Christiana's saying is the funding doesn't follow the referral, the funding is owned by the person, but that isn't that common, is it? There are personal budgets in some places, but I don't know how much they're integrated into social prescribing mechanisms. I think this is a big question for everyone. Gavin, you're clapping.
I was just agreeing, and now I can't stop clapping. I'm just going to have to carry on clapping for the rest of the meeting. Sorry about that. Oh, it's gone. Great, thank you. I was just agreeing with Christiana about that. I can add question.
To the thing. I think the thing with the funding, of course, we've got the National Academy for Social Prescribing in England, who are setting up regional hub. I mean, I think on the 10th, they are launching the Thriving Communities program, and what they're trying to do is to build capacity because social prescribing link workers are as good as what is out there in the community. So there's a recognition there is a need for that, but there needs to be some form of coordination. And then in some schemes, some of our members in Scotland, every program has got a capacity building fund where the link workers, then it's empowering the person, because if you identify this gap, there is no provision for the person, and then they can set up their own thing. Well, that's empowering. And it's not just that they're attracting European funding, various funding. So again, is the language. If we tailor this and have a narrow view where it's about NHS funding, well, you're not going to get other corporates and others who are passionate about social connectivity or improving the well-being of their population if we're just thinking that NHS is just going to be the only funder. So it's the way that we're actually selling this, you can use that word, opens up a number of opportunities. Then in some areas, they have a number of social prescriptions that are paid for, where people can signpost to. And then in some areas, it's all free resources at the moment. But from our perspective, what we are saying is that it must be about empowering a person and putting the person in the driving seat. And I would much prefer that the person can commission their own services, and maybe based on a menu of available options, but then they can actually create theirs if they don't fit in within those, as well as starting new groups.
Okay, fantastic. Thanks, Christiana. There's a question here which I might just respond to, which is, can you explain which specific streams of funding we are talking about for referral other than personalisation? When we talk about personalised care, that's really a whole approach. It's not about funding. Personal budgets is a type of funding that follows the person, and they have a degree of control over it. But that's not the same as on the referral routes. Obviously a referral to a drug has money attached to it. The prescription has money attached to it, but we're not in that position yet with social prescribing, as far as I know, though we may aim to be eventually. Okay, so I don't think there are any more questions shouting out at me here at the moment, but Helen, did you want to respond to something?
Yeah, so Sarah Kemp has posted a message which I think sort of relates to a point Christiana was making around, so her question is around how artists and how arts cultural organisations can get involved. So it's brilliant if you have a link worker in your area, but of course, you may not have a link worker yet who you could connect with, or, as Christiana can report, many link workers are already overwhelmed with the sheer volume of patients who are being referred their way. So I guess it would be useful, I think, I think Sarah's got a really crucial point, which is those organisations who want to support social prescribing and want to work more within their communities to deliver, say, health outcomes and support, communities and well-being. And I just, the work that people like Gavin at Hoot and Emily at Arts and Minds have been doing, and many other organisations. We work a lot with museums, as you know, but also libraries, outdoor spaces, wildlife trusts, etc. Is that, making that partnership link and thinking not just about linking up with potential people in your communities who might be marginalised, but who is working already in the community to support those audiences. So linking up, say, with adult psychological services, because as Christiana says, the link workers are really crucial at the point of a referral, but also what we're talking about here is how arts and culture can be better embedded into general prevention and intervention for our own well-being. So how everybody can get more engaged in arts and culture, and how that can be embedded into your organisation in terms of your strategy, in terms of how you deploy your funding, your assets, like your people. So
yes, and I'd just like to add to that, because Christiana referred to the Thriving Communities programme, which NASP is launching. And the key there, if you're thinking about applying for funding, is the partnership. So as Helen says, arts and cultural organisations cannot apply alone for this kind of thing. They have to be part of the whole social prescribing gamut of offers. So they have to be connected into sport, Natural England, into the sort of more support mechanisms around whether it's debt management or whatever. So you can find out information about that, how it's conceived of in terms of what you might call the providers of the prescriptions. But to get involved in that, as Helen says, the arts and cultural sector must be part of those partnerships. And so it's making relationships in your locality with other providers, I would say, is a critical step alongside understanding the mechanisms for link workers. Would you agree?
Yes, I think that's very helpful for us as well, because we just can't keep having everyone hunting down the one link worker who already have lots of workload. Some of them haven't got the capacity or money anyway. So it just makes sense. And that's why the NAPS work is really welcome, because then people can link in, and then also, again, being creative and linking in locally. So it's just all about that partnership and collaboration, which is what social prescribing is about. It's owned by everyone. It's owned by the cult and arts and heritage sector, physical activity, all the sectors. We're all in this together, because it's all our problem. We live complex lives, and the social factors do have an impact on our health and well-being. So it's just being some entrepreneurial spirit. And some people have got funding from elsewhere where they then say, okay, can you refer on to me? So it's just that networking and partnership and collaboration, but much more easier when you feed into your local networks, and then that way it's more easier to get access to you, rather than it being via the individual link worker.
Yeah, I think it's really important to get that across. Gavin, did you put your hand up?
Yeah, it was just that there are a few questions that have come up that I thought I could respond to, if that's
yeah,
useful.
please do.
There was one about personal payments, PIP payments, and we'd been talking about that a little bit. I think, just picking up on Christiana's point about social entrepreneurship and everything. PIP payments, I've looked into several different points in my career and it's a very problematic business model to try and develop, I would say. I think it's not easy to build sustainability based on those. That's my first comment. Somebody was talking about asking a question about, is this another way of getting service delivery on the cheap? I think there is a misconception that the voluntary sector, the charitable sector, is free. And I think that's something that we often have to confront and correct people about. But also, it depends where you are. We've got a national health service, but it's planned regionally. So you're always at the beck and call of what your local CCG and what your local commissioners, how their thinking is informed and how they choose to use their budgets to commission organisations. At Hoot, we're lucky we've got commissioners who commission 7 voluntary sector organisations to deliver a whole span of adult mental health services, and they've maintained that. The budget is tight for organisations, so there is, we have to bring in money from elsewhere to try and make it not so stressful to sustain as a service. And the other question was around access and tasters. How do people get access to things when they may not have tried it before? And I think that the fact that lots of organisations have had to shift to digital delivery because of COVID secure restrictions means that actually that offers us another pathway in to the work of organisations like Hoot or whoever you are, because it allows people to have those tasters without confronting the difficulties and the anxieties of actually entering a new, going over the threshold and entering a new place with people that you've never met before. And so it might offer some people tasters and different routes in, that once we're out the other end of COVID, they can then come into the buildings and be part of that in person, or they might choose to stay digital.
I think that's a very good, very practical suggestion around that question. But I think that question reflects something else, which is part of the other questions we've been discussing, which is, if it's self-directed, if it's co-production, if it's empowering, but people have never tried something, why would they come up with the idea that they would want to try an arts and cultural intervention, as it were? So I do think that there's a mix there around how do you generate interest in the work that you think, because we have an issue with access in the cultural sector. We don't have the breadth and diversity of engagement that we would all like. So those two play off each other, don't they? Lots of people are nodding their heads. Helen, did you want to reflect on that?
Yeah, I guess it goes back to my point. I guess that all the different organisations we've worked with, many scores of them over years, that's where they've seen successes, is where you're thinking specifically about within your organisation, what could I do to address diversity? What sorts of audiences could I work with? And as Gavin says, it is hard to make those connections, but you can start small and think about. We talked about in the past things like the JSNAs, the Joint Strategic Needs Assessments, and the framework that local authorities and the primary care networks and the trusts use to look at what are the major health concerns in your particular region. That is one place you can start. But thinking about what audiences are you not currently connecting with? And as you say, Alex, we know that many organisations would like to make those their services, their resources, their spaces more accessible. And I think if you embed well-being and creativity at the heart of that, when you're thinking about reaching out to audiences, I mean, you're thinking about making partnerships. I've seen some brilliant examples. We've heard about Hoot and Arts and Minds and many different organisations that have worked very, it takes a long time to build those sustainable partnerships. But even if you start with 10 individuals and 2 or 3 different partners in your organisation, from your organisation that you network with, that can span out to then thinking about expanding and then linking into when there are funding opportunities. So I really think it's about embedding it strategically in your organisation and how that changes in terms of, it might be, like I say, how you shift resources. And I've seen many organisations really shift their entire model, changing the titles of people's jobs to reflect how you embed well-being and diversity and inclusion in your organisation.
Thanks, Helen. Emily, I don't know if you want to say something, but we're supposed to be tying up now, so can you make it very quick?
Yeah, I was just a comment just about reaching different audiences. In lockdown, we adapted. We were due to start a face-to-face arts and prescription, and we adapted to an online version, which we hadn't done before. And we said to participants, this is a real experiment. Would you like to join us on the journey? And we got about 50% of people did. We now got some of those people who've just done a face-to-face before we go into lockdown 2. So we're going to be looking at doing focus groups to see their different experiences, but also going forwards, it provides an opportunity for a blended approach. And we did have feedback from one person who said, I've never been able to get into Cambridge. I could engage online. So there's that geographical interesting point to note.
Thank you. I know, Christiana, you wanted to say something, but I'm just going to do the end housekeeping information in case people have to leave on the dot, and then we've got 10 minutes extra. This is going to be kept open if you want to continue chatting. Any relevant links, slides or documents will be sent round afterwards, and this series of events is just a starting point. The Centre's keen for everyone to collectively work together to build a better understanding of the differences culture makes to people's lives and communities, and to help us shape these future events, could you take 5 minutes to complete the feedback form that has been put into the chat now, I think, and you can be in with a chance of winning a £50 book voucher in the prize draw, and you will also receive a link to it if you press the leave meeting button. Okay, so we've now got another 3 minutes, and Christiana, do you want to just respond to this issue around funding, because it's such a critical question for so many people?
Yeah, so I wanted to respond around the social prescribing and the cheap, and then talk broadly about the funding. The challenge is that social prescribing is trying to reverse the inverse care law, and it's about inequalities. So some of the people we support, they've really got no money, so it's about society recognizing. And one of the GPs that attended our Link Worker Day 2020 conference, he says that inequality is an unfair disadvantage. So we need to take responsibility and appreciate that there's certain people we need to pay, we need to actually fund for them to assess some of the social prescribing activities, and we then need to build in growth and sustainability. So in some of these schemes, I think there was one about football, and they've trained to become a coach, and now they've started their own kind of like service. Some of them have gone back into job, because there is no equality without economic empowerment. We need to make sure that communities are thriving if we want them to be paying. We've got people that we are supporting who've never worked, but now they are working, and then they're contributing to society. So it's about understanding what we're trying to do here. This is quite very massive. It's beyond any one sector. This is a very huge social and cultural change we are trying to actually enforce here. And we really, really need to understand it, and then take that holistic perspective in terms of the funding. So yes, there are areas in terms of funding, but of course, if it's not about addressing inequalities and helping those groups thrive, well, there is no finite, resources are quite rare. So it's not just about this is war. The sector is slowly capturing the social determinants of health and moving to a social model, but they do need evidence of why they should take money elsewhere and invest in this. How is it helping people? And it comes to making it very clear who is benefiting from this, what is its sustainability, how is it helping, and being aware that there are some that needs to be funded and paid for this until we're able to reverse the thing that the society have done to them, because this is an unfair thing, that inequality that has been created, and reverse all of those. Then we can have money to be paying for all of these. Otherwise, are we targeting people that already have the money? Then we need to be very clear. We can go to those that have got the money already.
Okay, well, thank you. And I think that that's a really important point to end on, because I think health inequalities, person-centered and co-production is not the terminology that is at the heart of the arts and cultural sector, I would suggest. And I think we really do need to move, our territory. Helen's talked about this. We need to really be able to think into other sectors' way of thinking and bridge these different ways of understanding what all of this work is about. But I'm going to shut up now and say thank you to you all. Please feel free to leave when you would like to, but we will stay here for another 10 minutes if anyone would like to have some informal chat. And thank you very, very much to all of our speakers and to the Centre for Cultural Value.